Okay, Sammy, can you hear me? Okay, we'll get started. The McGee family? Yes, I get, we've run camp now forever, so it's like, if you see people start to raise their hand like this, hands go up, mouths go shut. But I do want to say that one of the things about what we're going to be doing all day today and tomorrow morning is meeting each other. So, and be prepared. I see everybody sitting with their family. At the next session, I'm going to ask you to move around and sit differently. The way we're doing, so we have sessions all day. So the presenters are going to leave lots of times for questions, but also there's 15 minutes between each session to meet each other and talk. In your packets, there's, if you have questions, and there's cardboard, or there's no yes. So for questions, if someone doesn't feel comfortable, but hopefully you will, to ask your own questions. But if you don't, we can ask them for you. But we're all friends here, so I think everybody will be able to get out. So quick history. A year ago, we were asked to our partners at the National Hemophilia Foundation. I don't know if Maria's in here yet, but you'll meet Maria. To do a focus group with people with ultra rare conditions. And after I've been working in this field for about 30 years, and in 2011, we changed the name to Bleeding Disorders Alliance Illinois. And I had probably told everybody, we serve everybody with a bleeding disorder. And what I heard very clearly from that, what we heard very clearly from that focus group is, no, we don't. We do a very good job with hemophilia. We do a very good job with epidemiological milligrams. But one of the people, Sammy, I think I'll attribute it to you, is that I think it was you that said, I've been coming 7 years to BDAI events. If you've never said the name of my disorder, you're not serving me. I feel like a stepchild that's not being treated well. Well, for all of you who know me, that was a call to action. And we started a rare support group the next month. And you'll meet everybody from that. And you're all invited to join that because we have just monthly meetings that are just talking. So we just talk. I try to shut up because they don't have a bleeding disorder, but I try also to share what I know. And then the group, we've had a couple special guests around issues. So the next thing though was I got an opportunity through an organization called Global Genes that they were looking to do these meetups for people with rare conditions. And I put a grant in and we got it. So that's what brings us here today. So a big thank you to Global Genes to give us the seed money for this. They're not here, but at some point we'll say thank you to Global Genes. And the Hemophilia Alliance supported us. And then we have our other sponsors that I'll introduce. So I'm so excited you're here. It's really just a start. I want all of you to learn, ask questions, and think about being national leaders for people with ultra rare conditions. So I'm so pleased to introduce Dr. Michael Tarantino. He is one of our HTC doctors, but he is a researcher, scientist, and I call him a dog with a bone. If he and his team can't figure out what's going on with you, they won't stop till they do. So he's just a great person, and I'll tell you some about how he's caring for people with ultra rare. And Dr. T.
Good morning, everyone. Well, I wasn't surprised that Peter Bob talked about his inspiration to do this. I've been with each other for at least 20 years, I think. And that's the way I felt. That when there's a need, Bob addresses it. So thank you again for the invitation for me to come up and tell you about ultra rare bleeding disorders. I'll start with a little bit of an editorial, I guess. The more we sort of like tag these kinds of bleeding disorders as ultra or super rare or incredibly rare, we have to be careful about the attention we may not get because of it, right? Like Bob alluded, sometimes funding agencies like the National Institutes of Health look at impact and how many people are impacted. Well, I like to take the approach that if it impacts you, it's important, and we have to deal with every person with any kind of bleeding disorder with the same energy and the same investigations and the same strive to have the best treatment available. I think there's other encouraging news I just wanted to share with you. If you don't know already, there's a group that's been around for about 15 years now called ATHEN. Have you heard of ATHEN? Yeah, the American Thrombosis and Hemostasis Network. And that was a group that started out really to be sort of a clearinghouse for information about people with bleeding and clotting disorders. And it really has evolved to be sort of a leader now in studying rare side effects of medicines, rare disorders, ultra rare disorders. So there is a current study that we and I know the folks here in Chicago at the treatment centers here are participating in. It's called ATHEN 10. And it's a study particularly to gain information from folks with these so-called ultra rare bleeding disorders, so that we can say more than just, oh, a few people have been described with this or that. So that study aims to gather information on 12 to 1,300 people with types of hemophilia or bleeding disorders that aren't hemophilia A or hemophilia B. And I know that as of about a week ago, there were about 4 slots left on that study. So we've already gathered information on about 800 to 900 people. It's not just a questionnaire type of study. Blood samples are given, and even the genes associated with the rare bleeding disorder are going to be studied free of charge, of course. And it'll really open up for many of the unusual bleeding disorders some additional and crucial information. Okay, so with that, I will tell you that I get no information from Wikipedia, and I would encourage you not to do it either. There may be a blurb about factor 11 deficiency or alpha-2 antiplasmin deficiency on Wikipedia, but I'm here to tell you that the information is sometimes not corroborated. Even though Wikipedia has evolved over the years, it's not a evidence-based peer-reviewed type of information. So be careful about, I guess, overarchingly what you read on the internet.
We're gonna have to look at glossary that we put together and give us that's probably we spent people together that trying to find the best glossary to put together. So
Well, that's just one cartoon that to me helped me make the point. A few years ago, I gave a talk just entirely on where you should and shouldn't get your medical information. And my son, who's an engineer but he likes to cartoon, made this picture, and I asked him, Dominic, make me a cartoon that shows how hazardous Wikipedia might be, and this is what he came up with. Okay, so as Bob might have mentioned, I'm I'm from the Bleeding and Clotting Disorders Institute in Peoria, Illinois. That was founded in 2010. There are several federally recognized hemophilia treatment centers here in Chicago, in the Chicagoland area. And we're the only center in the downstate area. Well, we do go all over the state, but it's all in the downstate area. And we do these multidisciplinary clinics because we think that's the sort of the model to emulate. And we know that it's not the same wherever you go, but we encourage every center around the country to take that model seriously because we know it actually reduces problems, morbidity, mortality to people with hemophilia at least. We're trying to show that for other disorders like platelet disorders. Like we've expanded that model to platelet disorders, to women with any kind of bleeding or clotting disorder, and to people with clotted blood. And we have like a whole host of specialists because we take care of the whole patient, not just their platelet count or their factor VII level. It's the whole patient. And I'll just say, because I'm very grateful that a family here in Chicago recognized what we do and give us a nice donation to start the Beals Family Foundation Center for Research. So we do a lot of research to help understand rare and ultra-rare bleeding disorders. And just in full disclosure, I do work and participate and run clinical trials for several of the industry partners, serve as a consultant speaker for many of them too. We have program grants from the CDC and the federal government, the Health Resources and Services Administration. And like I mentioned, we do a lot of research. Okay, so I'm going to focus a fair amount on diagnosis, how we get to the diagnosis of an ultra-rare bleeding disorder. And as you can imagine, it takes not only expertise, but it takes like an open mind, right? Because this is sort of the analogy we hear in medical school all the time. When you hear hoofbeats coming toward you, most likely it's a horse. It could be the zebra. It could be the zebra with orange stripes. You never know. So you have to keep an open mind. Well, that's sort of. Some diagnoses are just easy, obvious, right? But most of the time, the ultra-rare bleeding disorders diagnoses are not so obvious. And it really takes not only a trained eye, but someone who has that inquisitiveness and is willing to listen to everything you say about yourself, and everything you say about your family, and their medical issues, to zero in on the proper diagnosis. Okay, so I want to start with just sort of a basic review of what coagulation is, how it happens in the body. And you'll see a lot of Roman numerals on little pictures. And those all represent elements of the system that helps you address a break in a blood vessel, right? Whether it comes from a scratch, cut, a surgeon's knife, how your body deals with that to stop bleeding. So let's cross our fingers and hope it works.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor VII. Finally leading to the activation of factor X. This factor Xa is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor X. Since the two pathways merge at the level of factor Xa, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor Xa, in combination with 5A, activates thrombin and induces the so-called thrombin burst. one molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor 10A in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
Right. Thank you to YouTube for putting that together. It made me think of like 25 years ago when I tried to do something like this. I had to have consultants from far and wide who charged a lot of money, and I'm sure this was made by a 21-year-old on his iPhone waiting for an Uber, you know. So, but you saw in there, and maybe some of those Roman numerals were familiar to you based on the blood disorder you might have, of how important some of them are, like factor 10, for example. Factor 10 is sort of like the hub of what helps us make a good blood clot. And it's part of the, you hear the term cascade, right? We start with a few molecules of what activates coagulation, and we end up with thousands of these molecules of thrombin that help us make the fibers that make the clot watertight, right? Because that's the whole goal. You want to make that clot area where the blood vessel is injured watertight, so nothing leaks out. Now, I want to, because I'm going to mention platelet disorder, rare platelet disorders a little bit. I want to show you another little video about how platelets are made, and that will sort of like set the stage for talking about things that can go wrong with your platelet number and your platelet function. So again, cross your fingers. And let's hope this works.
Thrombopoietin, or TPO, an endogenous hematopoietic growth factor, is the primary stimulator of platelet production. Synthesized in a constant amount, mainly by the liver, TPO acts within the bone marrow, specifically targeting megakaryocytes and their precursors. On the surface membranes of these cells, TPO binds to the extracellular domains of thrombopoietin receptors. TPO binding induces activation of receptor dimers, which triggers intracellular signaling pathways that promote proliferation, survival, and differentiation of megakaryocyte precursors into mature megakaryocytes.
I was just going to say, don't worry, I don't understand all of that either, but I can see if I can get back to that. The best part of this video is it's showing how the platelets are made. So they come from those big cells in your bone marrow, but the platelets are actually little fragments of those cells. Okay, I'll get it right. There we go.
That promote proliferation, survival, and differentiation of megakaryocyte precursors into mature megakaryocytes. Megakaryocytes are giant cells with multimodulated polyploid nuclei that extend long, thin cytoplasmic processes known as proplatelets into the bone marrow sinusoid, where they release thousands of platelets. These newly formed platelets then enter the circulation. TPO constantly stimulates platelet production, so there are sufficient numbers to maintain hemostasis.
Okay, so that's the beginning part of making a blood clot. Why did I even tell you this stuff? Because that molecule that's made in our livers, TPO or thrombopoietin, is required to make those platelets. Or your body doesn't make that very well at all. And there are some people that are born without the ability to make TPO, or the TPO they make doesn't function right, and they don't make platelets very well. The other thing is that your body only makes a certain amount of TPO every day. You can't stimulate your body to make more. It makes the same amount. So when you need more, because you've had an infection or something else is making your platelets leave the bloodstream too soon, your body can't do it. So that's a real dilemma. And there are some disorders of where TPO is made and made properly, but where it acts on the process of making a platelet, you're in this little sequence here, that part of the cell in that stage of development may be resistant to the TPO, and therefore you may make less platelets and less functional platelets than you want.
Can I ask a question?
Yes, of course.
Where you're showing where it releases the platelet, what if the platelet that gets released is not a totally functioning platelet?
Yeah, exactly.
Because that's where mine is.
Yeah,
My
okay.
platelet is,
So you will be very interested to see the next few slides because to get to that exactly. Okay, this is just a graph that sort of illustrates that point that your body only makes a certain amount of that. I mean, the body only makes a certain amount of that. Does sound like
Yeah.
that's not good.
Yeah. Feedback.
oh, okay. Okay. Freaky.
Sorry.
That's all right. Okay, so the blue bar on the left and the little red bar next to it means in a healthy person, the platelet count, the number is normal, and there's only a certain amount of TPO made, right? And the middle blue bar and red bar is an immune condition called ITP, where the body kind of destroys your platelets too fast. So that would be a perfect example and a perfect opportunity for your body to sort of ramp up the TPO to make more platelets because you need more in that situation, but it doesn't because it can't. Right? And there is a condition of people that are born without the ability to make platelets, and they don't destroy them prematurely. They just don't make them. Okay, and they have actually an increased amount of that TPO, not because they're making more, but because their TPO lasts longer in the bloodstream. So even though they make more of that TPO, their platelets aren't responding to it, and they end up having low platelets because of it. So that TPO molecule is vitally important to us being able to make platelets and make good platelets.
Now, platelets come in and the body.
At the beginning,
Blue.
no, at the beginning, they're at the beginning. They're the first thing that plug up the hole in your blood vessel, right? Like you saw in the picture.
Okay, the big thing is that and other factors support that staying there and
Staying there, but also making that watertight, right? Because those platelets, you can imagine, it's like marbles in a jar, right? There's still spaces between the edges of the marble, right? Stuff can leak through that. So the coagulation system and how we use that thrombin and how we make the fibrin mesh, that makes it watertight. Okay, so to your point, this is again a picture of the development of a stem cell that sort of changes and gets a signal to become when that big cell that the narrator talked about, the megakaryocyte, that then is used to produce platelets. And we have identified all of these different genes along the way in these different stages that have a big role in that happening. We've also identified mutations in all of those genes to show where, okay, this stage is going to get interrupted because this particular gene, like MYH9, for example, is mutated or changed. And therefore the structure of the megakaryocyte platelet's not going to be normal. And the result of that is going to be low platelets that don't work so well.
in the mutations we've identified that they were likely to occur with the cultural groups, with the ethnic groups, things like that, following family lines,
Right, that's a really good point. For the most part, these mutations that affect platelets, platelet function are typically found everywhere, anywhere in the world. There are a few disorders that I'll show you that cluster in certain parts of the world, and I'll mention those in a bit. Okay, so we have found mutations in all of these genes that can affect the way your platelets work. And I'll talk about measuring platelets and platelet function, but we now have panels that screen all these genes. Like there is a very world famous laboratory just up the road in Milwaukee called Versity. And they do a screening panel of 65 genes that affect platelet number and platelet function. And we've identified quite a few, and I'll show you in a minute why in some cases that's vitally important to the health of the person. Sometimes I get in trouble for this, but I say this is an example of where size matters. So when we look at the blood under the microscope, how big or small the platelet is under the microscope tells us what type of platelet disorder you might have. So if the platelets are very small, especially if you're a male, you could have one of these X-linked disorders called like Wiskott-Aldrich syndrome, for example, or X-linked thrombocytopenia. And then what's the first clue to that? Well, platelets are low for one. The second clue is they're small when I look at it. If they're big in size, in contrast, that takes me down a whole different path of what your platelet disorder might be. Like a very famous one that we always talk about and get tested on in our exams is BSS, Bernard-Soulier syndrome. I don't know if anyone's ever heard of that. Yeah. So that's a disorder of platelets where one of the proteins on the surface of the platelet isn't quite right. It affects the size and shape of the platelet, and it affects the way it helps do that initial process of plugging up the hole in the blood vessel. There are probably only about 100 people in the United States with Bernard-Soulier syndrome, but it's
I have another question.
yeah.
Do you really think there's only 100 or we've only identified 100? You used to get a case where you identified someone and helped you extract it and it's about 31 people.
Yeah, that's right. Right.
So do we really think there's only 100 or we just don't know about it? And it, because we inherited it.
Yeah, Bernard-Soulier is actually a good example of your point, Bob. That you know, are there more people out there that we just don't know and they just haven't been properly diagnosed? And that's likely true. That's likely true. In fact, in my career, several patients have come to me, not a lot, probably 4 or 5, with a diagnosis, a different diagnosis, a low platelet disorder diagnosis called ITP. And when I look at their blood under the microscope, I look for this size issue. Because in Bernard-Soulier syndrome, all the platelets are big. In ITP, some are big and some are not. So it's something as simple as that. It helped me make a correct diagnosis of Bernard-Soulier syndrome. And then I was able to use the Versity lab to do the molecular and genetic diagnosis that identified Bernard-Soulier syndrome and these people. Yes.
Do you have to go, do you have to go where they're often for them, or you can look at the blood and figure out what's wrong? I'm just kind of thinking of people who may have got HCP and their patients in the college, and it's so difficult to diagnose because the physician is not familiar with the diagnosis, and doesn't know what to look for in the blood.
That's such a good point. That's such a good point. So this is my opinion too. This is 2022, right? And we have a lot of technology, some right at our fingertips, some is right there if we take one extra step of effort. And then some, you know, it's difficult and we just have to do our best, right? So there are plenty of folks out there with low platelets, mildly low platelets, where their primary doctor or even their hematologist have said, you know, you look pretty healthy, your platelets are a little bit low, let's just leave it at that. Save yourself some resources and you know, let me know if you have trouble. There's lots of people out there. So, and I'll show you again in a minute, teasing about this, but I'll show you in a minute why that's not the right thing to do. The right thing to do is to do what you can to make the definitive diagnosis. Yes, of course. Right, so in type 2B von Willebrand disease and truthfully, with any blood disorder where the platelets are being destroyed prematurely, the platelets tend to be large, right? Because your body's constantly trying to replenish those platelets with new platelets, even though they're not lasting as long as they should. So they tend to be large. So type 2B von Willebrand disease is one of those problems where platelets get inappropriately activated and cleared out of the bloodstream. And because of that, the platelet count is low. But when we look at those platelets under the microscope, they're bigger than normal. Yes.
I wanted to talk about, what the inheritance, I heard it a few times, going around. So,
Did you say inherited?
inheritance,
Yes, yes, absolutely. I will.
okay, how, that takes a little, you guys want to.
Everything example here is inherited on this slide. And when I get to the coagulation disorders, I'll even show you when we know the inheritance pattern. That's so great. Thanks for reminding me not to neglect. Okay, so these two charts, and here it is, for platelets anyways. These two charts go through this list and details, like things that help us make the diagnosis, right? Because that's why I'm talking about this path to the right diagnosis. Here's a very sort of prototypic example. TAR syndrome. That stands for, does anybody know? Thrombocytopenia, that means low platelets, with absent radii. And you know what the radius is? That's that bone in your arm, right? Okay, so there is this genetic disorder, and it's identified to a gene that's listed over on the right there, that sort of connects the way your body makes platelets and the way your body grows that part of your arm. Okay. So whenever I see a child that has low platelets, one of the first things I do on the physical exam is look at their arm and their hand, because sometimes that radius bone is not even there at all, and sometimes it makes the thumb deform because you know you need all those bones being kind of growing in concert to make what looks like a healthy arm. So I'll always look at their hands, and even the muscle here, this thenar muscle, your thumb muscle there, because sometimes it's very subtle. Okay. So again, you gotta be thinking about that. You gotta have read about it, right? You gotta know what you need to know. But it is part of that diagnosis. In these myosin heavy chain disorders at the bottom, look at that. It can be associated with hearing loss and kidney problems. So I always want to know whether there's hearing problems in the child or the adult, or whether they have any problems with their kidneys. Even though their bleeding disorder may be mild and their platelet number may be not so bad, some of these other issues all tie together. We, like I said at the beginning, we have to take care of the whole person, not just the platelets. So that's a list of inherited thrombocytopenias with normal platelet function, just that the number is low, and because the number is not what it should be, there can be bleeding symptoms. I'll just mention a couple of things more about TAR just for interest. That I worked with one of our dentists at our treatment center. He retired a couple of years back, and for years I worked with him, and for years we would talk about platelet disorders and low platelets, and only after about 10 years did he tell me that his daughter had TAR. And he showed me a newspaper article from when she was a teenager in high school, and even though both of her arms stopped short just after her elbow, she became a tennis star, and actually went to the state tournament in tennis when she was in high school. That's one interesting tidbit. The other is that the low platelet problem goes away after 1 year. We haven't really figured out why that is, but something turns on a gene at that period of time. Before that year, those kids need platelet transfusions frequently. After that year, sometimes their platelet count is normal and they don't need any transfusions. So some mysteries we haven't solved yet, but very, very interesting and very very easy tip to at least be thinking about the diagnosis of TAR. So here are some inherited thrombocytopenias that have. Hello? Yes.
Diagnosed at birth or maybe prenatal, diagnosis.
Well, certainly the skeletal, the arm abnormalities can be picked up by ultrasound before birth,
Then because of that.
and sometimes it is. Now, TAR is pretty unusual. So usually when there's a skeletal abnormality, like a part of the limb or the hand is not developing right, sometimes it's actually a sort of a positional thing. And, certain proteins or even the cord can wrap around the arm at an early age and compromise the blood flow and cause a developmental problem. But again, too, Giselle, that sometimes that abnormality is very subtle. Like sometimes you look at the hand and arm and you think, oh, it's pretty normal. And then we get an X-ray, we see that the radius is not there. Well, it's connected somehow. Yeah, I'm not sure. That's a great question. I wish I knew the answer.
Now, again, and we'll have to talk about it a little more. There. Have someone with you had fun.
Yeah.
Probably.
No, you could, and it's very important, and I'll talk about it more with the coagulation disorder. It's very important to know whether the inherited problem is a recessive or a dominant problem, right? Because usually recessive disorders, they only come out if both parents carry that gene, right? The dominant disorders, it just takes one. So most of the platelet disorders I've talked about are dominant. Some are recessive though, like Bernard-Soulier syndrome, for example. That's a recessive disorder. It is an inherited thrombocytopenia. The platelets not only are low in number, but they don't work very well. And some people have terrible bleeding with it. It does vary quite a bit. I did have the distinct privilege of traveling to Ankara, Turkey during my fellowship, and I did a sabbatical in the lab of a very famous pediatric hematologist there, and studied 20 families with Bernard-Soulier syndrome. Like I mentioned to you, in the United States, we only know probably about 100. But in that one clinic on that one day, 20 families came to see me. And we did some genetic testing. But I asked all of them what their bleeding symptoms were, and it varied quite a bit. So some of the women were able to have babies without having terrible hemorrhage. Some lost their babies because of it. Okay, so here's just the take-home point on the last two slides, that there are other features that help us and give us clues to one of these inherited thrombocytopenias or inherited disorders of platelet function. I mentioned that every good hematologist will be in the lab looking at the blood smear of the person they're trying to help out, and there are clues even on that. I mentioned one earlier about the size of the platelet, but here in panel A up here, we see this big platelet that's one of these myosin heavy chain or MYH9 disorders. But we also see, probably a little bit hard to tell from back of the room, but the white blood cells where the arrow is here also have these weird little inclusions in them that aren't supposed to be there, that are called Dolly-like bodies. So I look for those too whenever I see someone with low platelet. I look for the size of the platelet, but I'm also looking at those white blood cells too. In the panel B, this is a disorder, you can barely see them, called gray platelet syndrome. Now, normally those platelets where these arrows are up here have granules, right? Like this one here, you can see this kind of like pink or purplish flush to there. Those are little tiny granules inside the platelet that have all kinds of important chemicals in them. In gray platelet syndrome, they're missing those granules. So the platelets look really pale. You can barely see them. So I look for that. I look for this here. And then sometimes we do electron microscopy to verify that. Because we want to know that it's not just, oh, the laboratory didn't like refresh their stain and it's stale or whatever. So sometimes we do electron microscopy, and that's what this is here. or from a person with great platelet syndrome. So you can see those dark little dots are those granules I spoke of, but in the great platelet syndrome, there's hardly any of them in there. And that, those granules have chemicals that are important to the way the platelets work. They're not there, and platelets don't work so well. And then finally, there's this other unusual disorder called Chidiac-Higashi syndrome, where we look for this particular type of white blood cell normally doesn't have these granules in it. You can see where my arrow is. So this white blood cell is called a neutrophil, and neutrophils aren't supposed to have granules in them like that. And the white blood cells or neutrophils in Chidiac-Higashi syndrome have those. So even though I'm more focused on the platelets, I still look for those. Make sure it couldn't be this particular one.
What does D represent? Your,
D is the person with great platelet syndrome to illustrate the lack of those granules, and C is a healthy person that doesn't have. Okay, so here's the thing I was teasing about earlier, right? Why you really want to like go the extra mile to make the diagnosis, because some of those inherited low platelet disorders can be precursors to later developing leukemia. So some are and some aren't. So you have to know which one. So you have to make that diagnosis to the degree that technology allows us to make it. And that means genetic testing. So some of these, and I'll point especially to this one called ETB6. That's the name of a mutation that does cause low platelets, but it also makes the red blood cells bigger than usual. So I get kind of very interested in looking for that mutation if I see big red blood cells and low platelets. Why? Because if they have that ETB6 mutation, some of those are predictive of developing leukemia or lymphoma. And I'll tell you a little quick story. For a long time in the center part of the state, and we go up to the Ottawa area for a clinic. I had been seeing this girl since she was, I don't know, 5 or 6 years old, and she had low platelets, and we really couldn't discern why. And her insurance company wouldn't allow us to do the genetic testing, and the family didn't have resources, and we didn't have the Athens 10 study going on, so we couldn't get it for free. So we just said, okay, we're just going to keep track of you. And then I met her father one day, who was kind of a stranger from the family. He came in and he said he had low platelets too. So immediately I thought, okay, this is an inherited low platelet disorder. But when he shook my hand, I noticed his thumb, and his thumb, the last joint of his thumb, like split into 2 thumbs. So very unusual, right? So I thought immediately, what should I have been thinking? Oh, is this like something related to TAR or, you know, a similar disorder? So I tried to do genetic testing in him, and he had no insurance, and then he disappeared for a while. So he came back several years later into the picture, only for me to find out that he had developed a precursor to leukemia, and he had a bone marrow transplant to cure that. So that made me think, oh my gosh, this could be one of those low platelet disorders that's inherited. And if my little patient, who is now 10, 11 years old, could be at risk for developing leukemia. So we did a bone marrow test on her. She was okay. Then eventually we convinced her insurance to allow us to do the genetic testing, and she had one of these ETB6 mutations. And in fact, it was an ETB6 mutation that hadn't been previously described. So I tested her father, because thankfully the Versity lab offered to do the family for free once they got paid for the girl's genetic testing. And sure enough, the girl had the ETB6 mutation, and that told me I have to watch very closely for the development of leukemia. And unfortunately, when she turned 13, she came in and she had signs of leukemia. I did another bone marrow test and made the diagnosis. She went to St. Jude, and now she's actually doing pretty well. But so important, not just to say, okay, your platelets are a little bit low, just kind of carry on, we'll take care of problems as they come. So this is just a slide. Obviously, there's a lot of detail on here, but the point is that even though the low platelets are mild, we still have to make the precise diagnosis because of other ramifications. This is just one of those pedigrees to show a family that had another similar mutation that can lead to leukemia. And you can see that it happens, that's the colored in dark circles and squares. And you know, on these pedigrees, each one represents male and female, right? And if there's a line through it, that means the person passed away. And if you can read the small print, where the square circle is colored in, there's the platelet count list. So all of these people had mild to moderately low platelets, and it happens in every generation. So that tells us it's a dominant trait, right? It's going to happen in every generation. It's a dominant trait. Okay, I'm going to shift gears a little bit and just tell you how in the general clinical laboratories, how we measure platelets and platelet function. The function screening tests are these two and one on the next slide. The template bleeding time, I don't know, has anyone here ever had a bleeding time test done? Okay. So you can understand why we don't do that test anymore, right? It's like caveman test, right? Someone comes at you with a lancet, pokes your arm, and then like as the blood flows out of it, they dab it with a piece of filter paper and they time how long it takes for it to stop. We use that test up until like 2000s, early 2000s. But this little machine is sort of a simulator for that whole test. So now they prick your finger and take a little drop of blood, put it in this machine, and it tells you essentially the same information. And that's called the platelet function and analysis, and the machine is called the platelet function analysis. Still the gold standard, and we have this very machine in our laboratory for measuring platelet function is called platelet aggregation. So basically we take a tube of your blood and we throw stuff in there to make to sort of encourage the platelets to clump together, almost like simulating the beginning phase of the clot formation. And if it happens with certain chemicals, good. If it doesn't, then we think, okay, maybe you have this or that disorder. Well, as you can see, that machine looks like it's from the 1980s, maybe 70s, right? And the technology has not really improved that much for platelet function testing. So even though we have some kind of what sounds like fairly fancy technology, it's a little bit archaic, and we do need better testing for platelet function. I'm not going to get into too much more else because it would take too much time. But if you have questions about other tests, yes. That's a wonderful question. Now, I don't know about in Chicago, I'm sure it's limited up here too, but in the whole downstate area, there are only 2 laboratories in the entire state of Illinois outside of County that do this test. One is at my center, and one is in Springfield. So we couldn't, we're a nonprofit, so we couldn't afford this machinery. I mean, the whole system is about $120,000 and has to be like serviced and very expensive to do. And the test takes 3 hours to do, and it's called a high labor intensity test. So that means one of my lab people has to sit by this machine and do stuff, put chemicals in and out of tubes and watch it. And it's time, you can see by the graph that's a tracing over time. So it takes about 3 hours to do that. So 3 hours of labor for a laboratory technologist. So we have a sort of a standard bill that's been determined by, insurance companies essentially of how much we could charge for that. And Medicaid pays us about 5 to 8% of that. So I lose resources and money whenever I do this test. But we're the only place in the area that does it. So I just do it.
I know at UIC, the head of the lab told me they will only do 1 platelet function test a day because of its own labor intensive. They said to them as a family, they tell them they cannot do more than 1 person in a day. So if there's 2 or 3 or 4 or 5 people, they will not do them all at one time.
You can see where that creates a dilemma, right? Because I just got done saying we should do everything we can to make a proper diagnosis, right? Sometimes our hands are tied.
So, speaking so labor intensive, is there a risk of tests being received from like human error?
Yes.
There is. So to help get around that, every time we run a sample for platelet aggregation, we run a healthy control. But do you know what that means? That means our laboratory technologist comes around the clinic, says, who wants to be the control today? And an ounce of blood has to be taken from that person. And this is not something where you can store the blood, right? You gotta do it right away, within 3 hours of getting the blood. So that makes it hard for her, because, you know, she's, when they see her walking around, they're like, oh, I took an aspirin today. I can't.
With, I think that we have with the platelet function test. I have learned, I have to make sure that where I'm gonna have the blood drawn, because I did this happened less than a year ago. They drew the blood, and instead of walking it over from Rush over to UIC, they sent it into the hospital, and it didn't get there for almost 4 hours. And it came back and it was totally nonsense. They repeated it. This time they only waited 2.5 hours, and it was huge. And you get to, you know, they used to at Rush, they used to have somebody standing there waiting to take the blood, and then that person would go downstairs to security, and security would drive them to UIC. But that is the crucial factor, is how soon they do the test.
Well, you bring up some very important points too, because when we put a blood sample in a taxi or a courier and they drive it across town, and the suspension on the car is not so great, and that blood tube like bounces around, and it can activate the platelets and make the test result not so good. So that's probably what you were alluding to, right? So we do this test for the Carl system, you know, in Champaign and Bloomington. We unfortunately have to make the patients come to us. They have to drive to our center. We don't want the bumpy ride for their platelets. It's gonna mess up the result.
Now, one of the things we're improving in our system, we're going to have transportation for the fact that you have to go to the guy, wherever you are in the state. We can be in the VAI, we're Illinois. We'll work with BCI, I mean, we actually to the facility for the test and support you. The PK study, 3 days, you can help with that. This is kind of critical that we get through these barriers. So don't let these barriers. When we talk about working with other people, then
Oh, yeah.
work with everybody.
Sure.
And you are protected. So if someone needed it, everything. We're in your current position,
What does it mean for?
your current position. Like, we're not looking, you don't take the patient. You know, not like-
Right. Yeah, we work with all the hematologists of the region, you know, that area of the state. So even though it's a hematologist patient from, you know, Champaign or Urbana or Bloomington, we'll do the test for them, but the patient has to come.
And even in Chicago, right?
Yeah, I mean, if there's no other way to do it, we'll do it for anybody. And like I said, it's not, there's no financial incentive to do it. There's a disincentive, but we have to be able to do it. So, okay, so how firm are we on time? Because,
Keep on.
okay, good.
Wait a minute.
Okay, so I'm gonna shift over to now away from the platelets a little bit to the coagulation part of how we make blood clot. And this is sort of like a paper two-dimensional representation of what the narrator said on that really cool video, that there's all these factors that are involved and they culminate in making those vibrant strands that polymerize, come together, form a very tight mesh that makes the clot watertight. And if anyone is in the audience with factor 13 deficiency, all the tests, the typical tests we have don't really screen for that, because factor 13 is AKA fibrin stabilizing factor. So it actually makes the clot even stronger to make it last long, not just to make it watertight at the moment, but to make it last. I'll talk more about that in a bit. Okay, so we do these times, and In the hospital, we call them coags or coag tests, but there's three particular tests that we do. One is called the prothrombin time or PT, and sometimes people for short call it the pro time. And when a person takes warfarin or Coumadin and they have to get their blood checked, that's what they're getting. They're getting a pro time. And then there's the activated partial thromboplastin time or PTT test. And then there's the factor assay, like how we know that it's factor 7 that's low or factor 11 that's low. We do that with what's called a one-stage assay. So basically, the endpoint of these tests is that generation of that fibrin strand stuff. And this is all done from the plasma or the liquid part of blood. And in that test tube that's drawn when they're taking your blood, it's got a little blue cap on it, and that means that inside of there's something called sodium citrate, and that takes the calcium out of the blood plasma, right? Because calcium, you need calcium to make the blood clot start. And then when the blood gets to the lab technician separates the red part from the plasma, and then to get the test started, they add the calcium back in, right, to get it going, and then record the time. So when your pro time is 14, that's 14 seconds. It means it's 14 seconds from the start of that test along that fibrin stump. Same with the PTT, although what they do to activate and start the process is a little different. So that allows us to check for different or screen for different factor function, right? So we classically think that the pro time tells us about factor 7, factor 10, 5, and 2. And the PTT tells us about 12, 11, 8, 9, 10, 5, and 2. Right, so if we do those two together and we get results, we can kind of interpret whether both are normal, one's abnormal, one's not, or both are normal. Okay. So we kind of repeat that test with one modification when we want to know what your factor this or that is exactly. And that's called a one-stage assay. So that's like a PTT test, but what we add to it is essentially plasma that's missing the factor we're interested in. So if we want to measure factor 8, for example, we'll add a reagent that has everything in it but factor 8. That means we rely on the person's plasma to supply the factor 8 needed to do that test. So if that person is also missing factor 8, then the factor 8 measurement's going to be 0, right? And we're going to see you have the A. Same for all the other factors. Same for factor 12, factor 9. Yes.
What if your PTT are totally normal and you're not missing factor, it won't pick it up then? For a platelet disorder,
So the PT and PTT are totally normal.
and I'm not missing any factor,
Okay.
so that makes it all, everything is normal then.
Right. So like I mentioned earlier, there's some factors that don't get screened properly by these tests. Factor 13 is like the prime example of that. So if someone has no factor 13 at all, 0, they have a pretty severe bleeding disorder. But these two tests are going to be normal. So we have to go another step beyond that, right? A different test. Okay, in the interest of time, I'm going to skip that one. But I put this together, this slide together for your reference on all those tests I mentioned with a couple of extras at the bottom. And what when those test results are abnormal, what should we be thinking about? Like even back to the platelet part of the talk. If the bleeding time is abnormal, that makes me think certain things. Like fibrinogen disorders, Lanzmann thrombocythemia, Bernard-Schwartz syndrome, severe von Willebrand disease. If the pro time is abnormal, I'm thinking right away factor 7 deficiency, a fibrinogen disorder, or possibly factor 2, factor 5, or factor 10. So these are like detective clues, right? Or detective tool that we use to get to the bottom of what's going wrong. The right-hand column to me is very important, right? Because I can say, let's do this or that test, but if it's not available, then we're back to square one. So I have to know, like in the region, like where my patients are going to go to get their testing done, whether that hospital can do a certain test. So I keep tabs on all. Just a very quick note to say that babies have sort of an immature coagulation system. So their numbers or their results are gonna be very different than if they're even 3 months old or if they're an older child or an adult. So I have to know that too, right? Because several occasions, the nursery or the neonatal intensive care unit will call me and say, oh my gosh, the PTT on this baby is 40 seconds. That's abnormal. It's not abnormal for a baby on day 1 of life. So that if that person were 10 years old instead of 1 day old, then yeah, maybe then it would be abnormal. But I have to know that and know how to interpret that. Okay, I'm going to talk about some more specific disorders of coagulation, and I'll conclude to talk about treatment. It would be very nice if we had one treatment that worked for everything, but we don't, right? So I'm going to talk to you about what treatment is appropriate for each disorder too. Just in the spirit of this ultra rare theme, right? I put together this slide of all the deficiencies we know about. So essentially for every factor we know about, we know that there are people with deficiencies of that particular factor. And occasionally they're combined. So we're writing a paper now for publication about people that have more than one bleeding disorder. So we have to find a new name, a new descriptor for that, like ultra rare,
And there's also.
super duper rare.
And thinking about specified. Right?
Sure. Well, see, what Bob's getting at, yeah, that's very important. With part of that is we just need to be a little more diligent in getting to the bottom of things, but Bob is correct. There are some people that come to our clinic that have a blood bleeding disorder of some kind, we just haven't put a label.
Several. I've noticed generally comes out of several needs.
Sometimes they do, yeah, absolutely.
How
Yes, sir.
do you have to go to that?
Well, like I mentioned in the beginning, we always look for a research study or a registry study that will do it for free. But then it all depends on the laboratory. So the genetics labs that we use in the region here are University in Milwaukee, Prevention Genetics up in central Wisconsin. And then there's a new company, I think it's Minnesota-based called Invitae. And if you look at the pricing for the same genetic test, not the same. Okay, so we do look at what the insurance company will allow, because they sometimes allow one company and not the other in their network. And then we look too at whether the testing facility will make some allowance for people that are underinsured or uninsured, etc.
We mentioned after the 10 again, so that people.
Right. There is that at the 10. There's only a few hundred spots left though, before it closes. And
That's where all we.
every day I'm taking more of those spots because I want all my people to have their genetic information. Yes, absolutely.
Now,
Is there a chance that they're gonna increase the numbers? That they're gonna take versus more than 100, that they can open it up again?
Well, I know the original number was not 12 to 1,300, and so it has been expanded already. But of course, that's all that all depends on funding. So I haven't heard that they're gonna or plan to expand it. So there is a little bit of a rush, no pun intended, around certain centers to have the people that need that testing to get enrolled in that. Yes, you had your hand up for a while.
My partner doctor, maybe that's 2 years old, that was born St. Joseph Hospital. They tested him for fact that he was sick, and they couldn't get his results, and so we had to have they didn't know how to do it. They didn't get results, so we had to do it again for children. Then we got results and doesn't have. But saying that it's changing, we have to be do the test for 0. What we did, we was like.
Okay, so right. Yeah, certain factors are are produced in lower amounts at the time of birth. So usually it's what we would consider like a false positive issue. Like, oh, I think he's got this, when really it's just his body not being mature enough and the liver not being mature enough. So if you have a normal value at that time, that's pretty good evidence he doesn't have it. Because you know, when someone has factor 13 deficiency, I'll talk about in a second, that's an autosomal recessive disorder, right? So both parents have to be carrying a gene, or there has to be some spontaneous mutation there. And usually, in order for it to be a significant bleeding disorder, that factor 13 level has to be quite low. So when you get a test result that's normal, and you know, if there is another person in the family with it, I usually repeat the testing just to be 100% sure. You don't want to hang your hat on one lab test, right? Because like someone else mentioned, it could be a spurious result. Especially if the child has any kind of unusual symptom of bleeding. You want to make sure that that's accurate diagnosis. Okay. Yeah, so I summarized what we do for these inherited bleeding disorders. And in the columns are the different types of treatment we have at our disposal. The old standby, if you're on a deserted island, you may only have plasma. We have to give that, but we like not to give that anymore. There's kind of a fraction of plasma that settles out when we cool it to 4 degrees. That's called cryohumidity. And that has 4 different factors: fibrinogen, factor 8, factor 13, and bundle disease. So that's actually a reasonable treatment for it. Now we have better stuff. So if you're in a remote place that just has cryo and you have one of those deficiencies, you can use it. There are these things called PCCs, prothrombin complex concentrates, that typically have factors 2, 9, and 10, and sometimes factor 7, depending on which branch it is. So you could potentially use it for those deficiencies, although for most of those we have better stuff. And then we have concentrates that are either direct from plasma, like one of our 2 available factor 13 concentrates is from plasma, and one is synthetic. Similarly for factor 9, factor 8, for factor 7, there is a plasma direct factor 7 that's not here in the US, but we have 2 different synthetic factor 7s on the market here in the US now. Thankfully, for years and years, it was just one, and now most recently we have another, and that's being represented by someone here at the meeting. Okay, so that's kind of a summary, sort of what to do, what's available to us. If you'll indulge me, I'll go through a few of these rare coagulation disorders, but I'm not going to go in detail because I see Dr. Maggio already here. And,
I'm not talking.
okay. Good to see you. Okay, so I'm going to start from the top and on that, what the narrator of that little video said is an intrinsic pathway. So there are people walking around with factor 12 deficiency, also called Hageman factor deficiency. But in short, we know that that doesn't cause a bleeding disorder, even if you don't have no factor 12. Why am I even mentioning it? Because if your factor 12 is 0 or very low, it'll make that PTT test very abnormal. Very abnormal. So when it's very abnormal, in my head, I know there's only a few things that do that. And one of them is low factor 12. Sometimes that information comes to me in a person who's about to undergo surgery, right? The surgeon does this screening coagulation test and calls me saying, that PTT test is very abnormal. What should I do? Okay. So then I think, okay, could it be factor 12 deficiency? And what do I do then? I measure the factor 12 specifically by that one stage assay I told you about earlier. No treatment is necessary to prevent bleeding, but ironically, people with severe factor 12 deficiency clot their blood too much and have DVTs or deep vein thrombosis. So we have to be very aware of that potential problem.
Factor 10, start looking for why.
No, that's the only one where you have that consideration. And Hageman, these factors have all kinds of names, right? Hageman is the name of a farmer in whom it was first discovered. And he died of a pulmonary embolism. So he died of a blood and not a bleeding. Factor 11 deficiency has a similar role in coagulation as factor 12. But if you're deficient in factor 11 completely, you have a bleeding disorder and potentially a very severe bleeding disorder. This is also inherited. It's not on the X chromosome, though. It's on an autosome, right? So that means it happens in males and females alike. It's clustered in areas where marriages and families are among first and second degree relatives, or we use this fancy term consanguinity. And there is a pocket in the Ashkenazi Jews. So a lot of the studies and publications that happen about factor 11 deficiency come from that part of the world. So the PTT test is long in factor 11 deficiency, and we confirm that by a factor 11 specific test.
And here in Chicago, with the big Jewish community, we have met quite a few people.
I was going to say Dr. Bajer probably takes care of quite a few. I have a handful of folks I take care of in Peoria with factor 11 deficiency.
And it's actually that people learn about their heritage by being.
Very interesting. Okay, we don't have a factor 11 concentrate here in the US. In Europe, there is one by one of the companies that's marketing factor 10. I don't know if they're here. But yes. Oh, there you are. Okay. So get us factor 11 here. Yes. Yes. Oh, you could probably tell me better than I can. I would, we've been sort of on that initiative for quite a few years. The trouble is that there's all kinds of regulatory stuff to get a product that's approved in Europe here. We have different oversight agencies, right? The FDA does not have jurisdiction there. They have their own deal, and our requirements for approval may be different. So that could require the company to do a whole new study, like start from scratch kind of study to test it in our population here. But I think with the right advocacy, consider this sort of like a part of a grassroots effort, then hopefully it'll happen in the next few years.
Yeah, we're working on our ambassador training, to train advocates. This is something to go talk to your elected officials and say, this is how it's been. In Europe, I need it.
Yeah.
Well, but again, your elected officials could also go to the FDA. They can go to the FDA and talk about. But they haven't.
Okay, that we can talk on offline, because that's a very important topic. Yeah, very practical topic, but we won't be able to solve it here. Okay, so some people are born without enough or without any factor 7. If you don't have any, it's a pretty serious bleeding disorder. It's of the ultra rares, it's the most common ultra rare type of bleeding. If I could confuse the nomenclature anymore. So, in this deficiency, the PT or the proton test is what's wrong, and that often makes us test for factor 7, especially if it's someone who has bleeding symptoms. We have to remember too that your body needs a certain vitamin to make factor 7, and that's vitamin K, right? So if a person is low in vitamin K, their factor 7 could be low, not severely low, not like 0, but it could be quite low. So what makes your vitamin K low? Because you get vitamin K in your green leafy vegetable type food, but half of your vitamin K that's in your body comes from bacteria that reside in your large intestine. So we all live in harmony with bacteria in our large intestine, right? And those bacteria make factor 7, and your body absorbs that and gets into the bloodstream from your large intestine. So things that can change that bacteria, the flu, like having diarrhea for one reason or another, taking antibiotics that can change those bacteria and produce less factor seven. So you can have what are kind of referred to as acquired factor seven deficiencies. But again, those are typically mild to moderate at most. But when we make a diagnosis, we have to make sure that it's not due to a vitamin H. And I think I mentioned we had 2 factor seven products on the market here. They're both synthetic, and they're both very effective. And I mean, fresh frozen plasma, we could use plasma, but that you know, again, if you're stranded on Gilligan's Island, and all you have is plasma, then use plasma. But otherwise, you get these synthetic ones. Factor 10 deficiency, Stewart-Crowder factor deficiency. That's pretty rare. There's also an acquired version of that, so you have to be very careful when you're making that factor 10 diagnosis. I don't know if you've all heard of this problem called sarcoidosis, that can lead to sort of a amyloidosis that can lead to a sort of an acquired low factor 10. So you have to be aware of that. In this case, both the PT test and the PT test are abnormal. So when I see both of them abnormal, I think, maybe the production site, the liver, is not right. So I think about liver disease, but when both are abnormal, I think about factor 10 deficiency. If someone has no factor 10 deficiency, very severe bleeding disorder, and typically prophylaxis, meaning receiving factor 10 on a regular basis to prevent bleeding, is what's recommended. And thankfully, we have a plasma-derived factor 10 concentrate on the market. It's been for several years. Factor 5 deficiency is very, very rare, about 1 in a million or less. It's also one that causes the PT and PT test to be abnormal. We don't have a factor 5 concentrate. I did take care of a woman who worked in a hospital laboratory with me, who had factor 5 deficiency, and she was always very anemic because her menstrual periods were just incredibly heavy. She did want to have extra. So we have to unfortunately use plasma when we want to treat someone with factor 5 deficiency who needs surgery or has bleeding. Wind it down here. Remember from the video, the enzyme that is the most important enzyme to make those fibrin strands is thrombin. It comes from prothrombin, that's factor 2. And there is a deficiency of prothrombin that's known. It was identified by this person who was from around here, right? Online quick. And he was the guy who invented that ProTime test. Very famous guy. And he wrote a book, and he described a little girl who he, long story short, diagnosed with prothrombin deficiency. The funny part of the story is this is back in the 40s, and he went to the parents of this girl, said, I really want your daughter to come and live with me for a year so I can study her. The parents were like, but oh, I only know this because I met this person. I met the little girl who, when I met her, was in her 60s and still a healthy person. And she said her parents flatly told Dr. Quick where to take that idea. He said, well, you come with me and my wife. It's not just okay. But anyways, right, so it's very rare. There is a sort of a related, even more rare disorder. It's probably the most rare, ultra rare disorder called dysprothrombin, where the prothrombin is made, but it's just not a normal molecule. But anyways, severe factor 2 deficiency, very terrible bleeding disorder. Usually replacement has to happen. In many cases, it needs to be prophylactic. There's not a prothrombin recombinant concentrate. It has to come from plasma or one of those PCC concentrates I mentioned to you before that has factor 2. And then a whole sort of category of what are called congenital fibrinogen disorders. And you can see there's sort of like subcategories here. Afibrinogenemia, when you don't make any Hypo when you don't make the knob. This, usually when you see DYS in front of a word, it means something's not working right. So you make it, but it doesn't work right. And serendipitously, that can cause both clotting and bleeding, and even in the same person. We have several patients we follow, and what Bob was alluding to earlier is a very large kindred of individuals, about 600 or so in the family. Many of them have that dysfibrin. Inheritance is recessive for the severe afibrinogenemia, but for the dysfibrinogenemia, it's dominant. So that's why in the kindred that lives largely around Peoria, many people have it, and it's in every generation. If you don't have any at all, you pretty much pick it up right away because there's bleeding symptoms right from birth. And if you only have hypo, meaning it's low but not that low, sometimes it goes undiagnosed for years, even decades. So here again, the PT test are abnormal. And when we measure the fibrinogen, we both measure the function of it and how much is there. Because we want to distinguish between, is it just low or do you have the stuff that's not working right? There are 2 fibrinogen, plasma-derived fibrinogen concentrates on the market, and I think those are the best therapies. But that cryo stuff I mentioned earlier and plasma both have fibrinogen. I have this sort of special connection to factor 13 deficiency. It was one of the first patients I took care of when I was on the faculty in Louisville. That was my first job. It was actually a little boy whose mom was being accused of child abuse. When in fact, the brother of this little boy in the backseat of the car took the seatbelt and whacked him in the face with it to get a big old bruise. And the mother was, of course, accused of doing harm to her child. I was called in to say what's going on because the team said, well, that PT test is okay, and the PT2 test is okay, and the platelet count is okay, the platelet function is okay, what could this be? And from an earlier sort of reading and study that I did, I said, have you measured factor 13? When we did, this factor 13 was close to 0. Thankfully, it came out because, as you know, when you have severe factor 13 deficiency, about 20% will develop intracranial hemorrhage during their lifetime. So the standard of care is to get factor 13 preventatively. And we have 2 concentrates. We have a plasma-derived concentrate that's good for all types. And we have a synthetic one that's good for sort of a subcategory of special type of factor 13. Say what? Right from Nova Nordisk. Okay. So that's the synthetic one. Okay, so this is my sort of like personal feeling about when someone says, oh, it's rare. It's rare until you have it, right? When you have it, it means everything, right? And it's not rare within your family. So sometimes habits do that to you, right? Okay, so I'm going to close there. I don't know. I think we're over time. I'm happy to take questions as long as Dr. Bosch is okay.
Yeah, that's what we thought we do, we don't want to call.
Oh, yeah. Well, yeah. Did you have a quickie and then Dr. Bosch?
I just wanted to see your factor 5 slide one more time.
Sure.
Or maybe do that question, then maybe a lot of them will be great.
I'll be easier.
Okay.
Lisa,
All right.
please have Lisa Bashio from Roche with us.
Yeah, well, this question you get into. We want to have a direct. Okay. Oh. He's gonna be lost without his phone. Oh, no, I just wanted, I'm gonna be like those on you. If you're older, you know who that is, if you're not. All right, so that was a lot of, because I think it's not, I talk about it, doesn't make a lot of sense, right? Because I think Dr. Tarantino talked about all the products that are available, but And, I think it's better to know what questions people have, and then we can have different, discussions. Yes. I'm next gonna be- I have to be doctory, because I have to have a mask.
So my son has factor 13 and I just read the factor 13, men, I'm a warrior, of course, I'm a mom, I worry about my kids. Well, I'm a warrior too. All of those. But I was just reading that, I was curious about the men are likely to have infertility and, is that something I need to worry about? If I'm gonna have grandchildren?
Well, not necessarily, I mean, really, the infertility of things could happen because of bleeding, there could be other reasons, women can have miscarriages, it's very common with women factor 13 deficiency. To have recurrent miscarriages, and the prophylaxis, which is once a month, prophylaxis, helps prevent problems from those reasons. It's partly the infertility could be related to where the mutation for the gene is on the chromosome, and it's close to issues that occur with fertility.
So, do you know where the person who discovered factor 13 lives? Here in Chicago. I don't know if he's still alive. Yeah. So, so like I mentioned to you, I had a sort of a special interest in factor 13. And before I applied for a grant to study it, I came up here to talk about it. Yeah. And I'll just tell you a funny story quickly. I came up, he's on the Northwestern campus, and I parked my car, and he's in one of the buildings that there are two buildings that look exactly alike, right? Okay, and of course I went to the wrong one, right? And he's an old guy from Poland, I think, or Czech. Yeah, okay. So I walk into his office and I say, hey, I'm here, I'm sorry, I'm late. He looked at me over his glasses and said, I thought you were supposed to be an intelligent man. Right. I'm like, oh God, okay. Gotta step up my game here. Okay, so one of the things I learned from him though, is that factor 13 has other roles besides stabilizing fiber and stabilizing blood flow. So it has an important role apparently in how blood vessels grow and develop, right? Because experiments have been done in animals where they, knocked out the factor 13 and they see certain blood vessels not growing properly. So I don't know if it has anything to do with the infertility issue or not. Could be.
Because I did the angiogenesis. With my
Yeah.
project.
There you go.
So, yeah.
Yeah, that we use that term, angiogenesis, how blood vessels grow. So factor 13 is very important. We know that, like in babies, the reason I was trying to study this is because I wanted to have a better explanation of why premature babies have bleeding inside their brains, right? We know what happens, we just think, oh, the blood vessels are fragile, but why are they fragile? So we know now that factor 13 actually helps with the integrity of those growing blood vessels. So I tried to do a study to look at, is the lack of 13, like a low level of 13, related to the likelihood of having a bleed inside the brain. So yeah, I think there's other roles there, more to discover about that for sure.
And I think a lot of the clotting factors have other roles besides, and you should be aware of that. It's not just stopping bleeding. They work at nerves, they work at muscles, they work in the blood vessels, they do other things. And if people aren't aware of it, that's partly why the heme, like factor 8 deficiency, there's a fake 8 called heme libra that only helps with the clotting part, but doesn't help with the factor 8 needed in other places. So we're not, sometimes we're not sure what other, I don't know, but we're Italian. Bob, we gotta move. It's the way we are. We can't talk without our hands like how do you cut up, how do you gag in Italian? You bind your hands.
I think you guys are both
have so much expertise, and Dr. Baja, I know you personally, and you mentioned that you consulted on a case, I think it was a Factor 13. Is that common? Like, are you guys able to consult with other hospitals who maybe don't have or struggling with a very unique case, or outside maybe your network, maybe smaller community hospitals? Are you guys available? Is that possible within, I mean, Brush to consult with smaller hospitals to consult?
I get calls all the time about different conditions, different bleeding disorders, not even rare bleeding disorders. That other hospitals, because it like, for example, in Chicago, nobody carries these factors. Well, nobody carries these factors unless you're at a university hospital. So in Chicago, Rush, Northwestern, maybe County, there's no use. That's Northwestern. And the least of mine is Northwestern. That's all that you can get. So that's why if you have a use for, it's important to have your emergency dose factor that you bring with you. But for diagnosis, we get called all the time.
Yeah, that, well, two things to say. That's kind of the way, that's kind of the standard of medical communication now. In the old days before we had the internet and email and such, it was a little more cumbersome. And, you know, doctors, they're a little more reluctant to, you know, pick up the phone and call somebody when they have to talk voice to voice. But that's not that they shouldn't do it. But I think maybe what might be an undertone to your question is that sometimes you're dealing with the egos of medical professionals. And they feel maybe like they're a little like hurt or insulted if that were even suggested, right? So that's where you have to sort of have that empowerment and have enough education to know I need to ask the question. And maybe it's not, maybe it's going to be with another doctor. So the nice way and the, you know, sort of the courteous way is to ask your provider, your physician, do you mind talking to a specialist I know at Rush or Northwestern or Peoria or wherever? But you might meet resistance when you make that suggestion. I think you have to be prepared to, you know, advocate for yourself or your family and do what's needed. And that might mean you contacting the person.
We're also gonna talk about research a little bit later on. One on registries. Have we heard about registries? Do you know what they are? Patient registries.
When you come to clinic and ask you to sign an ACM consent, because you have a bleeding or clotting disorder, you're on a registry, which means your name isn't necessarily specific, but that data is there about how many people have this condition, how many people have that condition. And speaking of Athens over there, you get free genetic testing for rare bleeding disorders through Athens 10. So go to your HTC if you want to get that test done, because now they've opened it up to unlimited amount of people until funding runs out. So
Registries, and you as a patient have data information. You might not be able to get it, but you can work with the registry to say, I have this, or I have this, and you can meet other patients, and you can hear about other kids. You know, you can learn from each other too. You might find out they went to Rush, they went to BCI, and it might help you to direct. To say to your doctor, I found somebody who's a specialist in this, but we work together.
well, we also like to provide letters, treatment letters for people. So that if they go end up someplace else, now luckily, good,
They have.
yeah, but if you've seen us, we do a letter. And with many hospitals have Epic as their electronic medical record, not everybody does, but many do. And they can see our notes if we're there as well with the treatment plan. We put a treatment plan in for everybody, but that's something that you should have. Because if you travel, you go someplace else, they're not gonna know who you are. Having that travel letter is important of what you get treated with. Your treatment plan, having your factor with you when you go, or what your, if you have factors for your condition, there's that as well. And then the other part is like people who haven't been diagnosed and they go to the hospital for evaluation. I just had, you know, we offset that by, we have fellows come We train people from medical schools, we have fellows from other hospitals, like I have people from the University of Chicago. University of Chicago does not have a HTC, Loyola does not have an HTC. We try to get the fellows in there so that we can teach them about bleeding disorders, and guess what, then, someone else has been seeing somebody who's bleeding, then I get a call from the fellow. The former fellow or the fellow that says, oh, this might be somebody who'd be reasonable, right, so.
After people have their medical ID, for instance. You don't have one in Illinois, see Lily or Tamara, and we'll get you an application. And we'll tell you how to get your HTC. We'll tell you. We provide them free.
I have a question, Dr. Barnes, my doctor. I have factor 7, so, I'm going through like a stage with my son with no, so I want to know if factor 7 is genetic. Cause I'm the only one so far in my family that have factor 7, like, I don't know anyone with bleeding disorder or nothing on my mom's side or my dad's side. But like these past couple of months been so tragic for me with my son with the nosebleeds. Like he just had, that's what took the so long to come down. Because he just had one right before we got dressed. So it's like, I don't know, like, what do I do next? Like I took him to the doctor Tuesday, she was just saying like, oh, his factor 7 levels is fine, but what is the next step I need to do? Following his nosebleeds.
So, the evaluation by a hematologist might be in your future. But there are other reasons for nosebleeds too, but because the sevens are there, I mean, it, fine, I don't know what fine means as far as the level is, but there are other things that cause nosebleeds, right? Your nose is dry, you have a blood vessel that's pulp, a little bit big, and it's through the ENT, the ear, nose, and the doctor, they just go, as if you do know. And zip it up, but it is a genetic disorder. And since Tarantino said, you have 2 chromosomes that code for factor 7. If one is down, you might have normal levels, but you still carry that mutation. And severe deficiencies often both are down. And that's where the severe condition comes from, the more severe or lower levels. And like he also said, vitamin K is really important as well to maintain those levels if you're kind of that marginal person. This is my little finger, my chromosome. Yeah, my finger chromosome. That's there, but it is genetic. And if you have factor 7 deficiencies, a 50-50 chance you're going to pass one of the gene on to the kids. Each kid, if you have 2 copies, each kid will carry it anyway. So that's why that genetic testing could be really important to see what the gene mutation is, and then we can even for that. Sometimes the levels are so variable with stress and getting the blood drawn, and who wants to get their blood drawn? We're hematologists, we love blood, but nobody wants to get it drawn, right? But that's the big thing for that.
And as a factor 7 carrier, and you have bleeding.
Yeah, if you're it's just not as the hard part with factor 7 is that the level isn't necessarily all that predictive of bleeding. If you have 1 copy, it's weird. Let's just put it that way.
Hello, earlier we saw some slides about the different gene mutations and I saw that TERT was up there. So what is the connection between the TERT gene mutation and bleeding?
Okay, so this whole sort of science of telomeres and telomere length, like how big a certain part of the chromosome is from the connection point, is evolving. Like 25 years ago, we never talked about telomeres, and now we're starting to make associations with it. So like, for example, on this slide, I think this is one you're referring to. On this slide, all those genes are associated with something that's not right with, platelets. But also associated with something else, like a bone marrow problem, bone marrow failure, a predisposition to leukemia. So the science is evolving, but we don't have those precise connections to what protein. We know that there's a gene marker, but we don't know exactly how the protein affects both things necessarily. So, oh, no, it's the opposite, right? Yeah, so, like from this paper, for example, it's a very nice review. Much of this is discovered in the opposite direction, right? So people that have these bone marrow or leukemic conditions were also then identified as having low platelets in the time before their bone marrow diagnosis. So yeah, right. So because of that, this is like, okay, I see the scene of the crime and I gotta go back and figure out what the connection was or how it happened. And okay, oh, yeah, that's a good point. So, yeah, some of these on this particular list are not associated, but oh, the question, is the TERT mutation, the TERT gene associated with factor 11 deficiency? Right. So, a lot more people are getting like telomere length measurements and genes tested for not randomly, but just sort of as a comprehensive look at, okay, what could be going on here? Like, for example, I see Dr. Baggio knows I have a very big interest in ITP, that immune platelet disorder. And many patients that come to me, especially if they come from another university, have had their telomere length measured and telomere genes looked at. And there's no connection as far as I know, but now we have these two pieces of information, and we have to figure out, okay, how are they really connected? So as far as I know, there's no connection between TERT and factor 11 deficiency. Yeah.
I don't think we know what that TERT mutation means anyway. I am luckily 2 doors down from the geneticist in my office. So I get these genes and she goes, I don't know what it means. So we get all these gene mutations. We know as we age, our telomeres get shorter. I mean, that's not uncommon. But I don't think we know yet. We don't know much anything. He had a question first, so going on.
Quick question, and my wife and kids all have eating disorder. My wife, I think, a platelet disorder, some problem. For your slide on, you said like disorder relationship with the kidney problem. What's behind it? You know, my wife also has, kidney problem. Yeah.
There's a set of platelet disorders called a MY9 disorders. I don't know slide on that is associated with kidney problems. There's some platelet disorders associated with eczema. There's some platelet disorders associated with hearing loss. It depends on the gene mutation, and then you've got that here.
Yeah, in the old days, there were like specific names for each of them. Like you might have come across the names like Sebastian syndrome, Epstein syndrome, Beckner syndrome. So those were all sort of studied almost independently, found that the same mutation was coming up for all of them. And so some of them have not only large platelets that are low in number, but they also have sensory neural hearing loss that wasn't related to like an antibiotic exposure as a baby or meningitis. That's the reason for hearing loss. And a protein losing kidney problem. So the kidneys don't filter the protein problem. So myosin is a protein, like a muscle protein. And it is sort of like part of the integrity of certain blood vessels, like arteries, especially in arterial. So it's thought that maybe there's, you know, the connection between why your platelets end up big, because the scaffolding that makes the shape of the platelet gets messed up, and they end up not. You remember from the video how the platelets butt off of the little projection? So the body doesn't happen properly, and you end up with these big platelets. So there's probably a common theme to why each of those organs don't develop properly. But like I said, if there is that, there's very simple genes for that. Now, I can say that because I'm not the one performing the test, but within that gene, you know, it's a large gene complex. There have been, I think at this point now, over 100 different mutations identified in the gene, and we actually reported on a novel one as well to add to the collection. But those companies like Invitae and Prevention Genetics, and I believe Versity now does the gene sequencing in the mouse and everything.
That's good. It's good. Interesting. That's the thing about having those genetic tests. We know all the genes, but what can we do about it? It's a different question. But thank you.
On your factor V slide, so my son has severe factor V deficiency. You have on there for treatment that solvent detergent FFP may be more reliable than the standard. So is that being used right now as the solvent or not yet?
So solvent detergent is a little bit different because that's one of the methods to sort of purify things, but we don't have it available.
There is a product here in the US, and I think it's made by Octa Pharma, the German plasma company. So it's called Plaz SD, I think. Yeah. So the nice thing about the solvent detergent treated plasma is that it contracts the volume, so it's much smaller volume. So it's more concentrated proteins that are in the plasma. So you know, and the companies that make it, they sample their product and they look, well, how much factor V is in there, how much factor 10 is in there, etc. So you have a little better idea, not precise. You have a better idea of how much factor V is in there in a smaller volume. The trouble with that is that it's a pooled product, right? So when you get a unit of plasma in the hospital, it comes from the blood bank, and that's the amount of plasma that the laboratory spins off of 1 unit of blood donated. It's the liquid part of 1 unit of blood. So it comes from one person. If you get 2 units, it probably comes from 2 different people. If you get Plaz SD or a solvent detergent treated plasma concentrate, that comes from 20+ thousand donors, right? Okay, so there's maybe a little more safety concern about transmitting some germs, you know, that you don't want. So because of that, they do that solvent detergent treatment. But that's a cleansing process that takes care of most viruses and other germs, but some it doesn't, right? So some of the plasma derived or the solvent detergent treated plasma has been contaminated with viruses that don't get kicked out by the solvent detergent. One of them was this parvovirus, right? The dog virus that causes the red cheek fever disease. Yeah. So any product that's in that solvent detergent category is always at risk for transmitting some viruses that aren't taken care of by that process. So a good concept, but it's not perfect.
I'll make it 2 over the first.
Thank you. No, thanks. Thank you. I lost track of where we're supposed to go.
I wanted to piggyback off his question with the liver, your wife. My daughter is currently having a lot of like autoimmune things going on, and I was wondering if there was a link to that. And because her doctors, it's like a mystery to them. they said they don't have an answer for me. She can't go to school. She's tired. She gets hives on her body and swelling, edema around her eyes where they close up. And they did all kinds of testing on her, but I need to see if there's any kind of further, and she had eczema and other things going on. And when she was a baby, she had to stay in the hospital longer because she had under the bilirubin thingy for her liver. So I'm just wondering if I should follow up or, factor 13.
Is she getting therapy? What therapy is she getting for the factor 13 deficiency? So she's not getting any therapy for the factor 13 deficiency. So there's no association with autoimmune disorders and factor 13 deficiency to my knowledge, and this is different.
Yeah, I agree with Dr. Baggio. There is maybe an additional consideration, since there is like a dilemma here, right? Not sure what's going on exactly. There is a condition called acquired factor 13 deficiency. So if there hasn't been genetics done on your family to say that there is a mutation in the factor 13 gene, then there should be a consideration for, is this an acquired situation? And there are some not sort of like prototype autoimmune disorders associated with acquired factor 13 deficiency, but it's often diagnosed in people that have other inflammatory conditions, like inflammatory bowel disease, for example. Yeah, so, and there is a way to screen for it, and I know that the Mayo Lab, because we, if you want to talk about, super duper rare disorders, acquired factor 13 deficiency, it's super duper rare. Yeah, but if for some reason the planet's got wrong alignment and we get two people unrelated come to us within a year and a half and acquired factor 13 deficiency, and they both had inflammatory conditions. And Mayo was able to distinguish it with an inhibitor test for factor 13. So you might ask your physician about testing for acquired factor 13.
What about symptomatic carriers?
There is no such thing as a symptomatic carrier. Symptomatic carrier what? Exactly, I can hear where that came from. But there is no such thing as a symptomatic carrier, factor 8 or factor 9, they have hemophobia. So you have the condition, there's no such thing as a symptom. I mean, in my mind, the word symptomatic carrier, it puts me on my box. Yeah, that's what, exactly.
So, because I have a mild factor 10 deficiency of plate dysfunction. I've had some friends who I've met through other conferences who they're considered a carrier, but they still have high symptoms for what they have symptoms of people as if they had it. Yes.
Yeah, so my point is, the term, this is my soapbox, the term symptomatic carrier makes me insane. And you saw how I reacted, I'm insane, because it downgrades people. It sort of says, oh, you don't have a bleeding disorder, you're just a carrier. Oh, I hate that, it drives me nuts. If you're bleeding, you have a bleeding disorder. Because the labs aren't. That's my point, is that they may have been told that, but that's old thinking. And we want new thinking. We want to say, listen, we have to treat the symptoms. Bleeding is bleeding, right? Treat the bleeding, not just looking at the lab. Sometimes you have to treat the patient, not the lab test, right? Am I testing the lab? It doesn't make sense to me, but I get a little passionate about it. All right, little passion.
I have to say, we had a mom at our last block who was walking around with a whole food on. And she had been kicked, she was a teacher, she'd been kicked. For 9 months, she was being orthopedic, and I said, have you seen new colleagues? She said, why would I see new colleagues? I'm the carrier. And we got her to the HCC, and here for 9 months, she had been bleeding into that. So she had 9 months worth of damage to that ankle, that needed the blood being there. But everybody told her she was a carrier, and no one was treating her for And then she worked in a special hospital and student case. So.
I have a question, like, if you're genetic.
So I think if I'm reading your mind correctly, you were asking why do some carriers have bleeding and some don't, right?
Yeah.
What makes the person with, half the amount of factor 10 you're supposed to have symptoms or not? So here's one model that factor 10 is also one of those factors that require vitamin K, right? So your vitamin K is gonna fluctuate. It depends on whether you're going to the salad bar or whether you're going to the top, right? And whether or not you have the flu, or whether or not you take an antibiotic, all those things will affect your vitamin K, and then they're going to affect your factor count. So you normally, when everything is static, you have 50% factor 10 activity. It may dip down to 25% because of your vitamin K. And the health are different. Now, you look too young to drink, so and correcting your liver with alcohol is another thing. So think about that when you might want to go out for immediately. Okay, so we always sort of reserve. This is that part of the keeping your options open. That you're a person with a gazillion genes, and one that you know about is got a problem with factor 10. But you have other ones that could be modifying the way your body deals with the low factor 10. So you might have some subtle deficiency elsewhere that wouldn't normally hit the radar. But the fact that your factor 10 is only what it should be are causing you to be more than the average person carry. I don't want to say it that about it. The platelet problem. So that's an example. If you have platelet dysfunction, maybe it's genetically identifiable. That should be looked into if it hasn't already. And that may explain more or less symptoms with your factor 10 modification.
I have a question, this is dealt with your genetics. I'm positive my mother had an inherited bleeding disorder. Every time she had surgery, she would hemorrhage, and to the point that she would refuse to have any surgeries because she'd be hemorrhaging for days. And apparently they must have looked at factor. With the genetic testing, be able to diagnose what she would have had, because even though I've been diagnosed with dense body storage pool disease, which my father has, I still hemorrhage. And would that be able to help diagnose what she would have had?
Well,
that's
she's a go around the area. I think, first going to Dr. Baggio,
Yeah.
start from scratch, right?
It's complicated.
And then you do the whole look at what other people see, right? So.
Yeah.
I mean,
And just randomly doing genetic testing, we don't have that ability to do all the genetic, unless, well, we have the ability, it'll cost 5,000 out of pocket minimum,
like the price of,
or
Plasma screen TVs, when it's just like genetic testing. When plasma screen TVs first came out, like by today's standard, a crappy TV would cost $10,000. Like now it's $100. Genetic testing is the same way. When we used to look for like single gene mutation, it would cost $1,500 to $2,500 per gene. And now we can get whole genome sequencing for $500.
Would the genome testing show an inherited one?
Well, it depends on how that's done, right? If we know even a short list of genes we want to look for, then we focus on those, right? But when we just do a genome scan, then you get all comers, and even like minor changes in the genes that we call polymorphisms that might not mean anything at all. So there needs to be like a follow through with that information. It has to be interpreted properly.
Okay.
It's a much more complex question. I get a lot of factor 13 deficiency, H63D mutations found on pregnancy screening, which doesn't matter. Doesn't cause a bleeding disorder, so it's not an issue. So that's part of the problem. You get a G mutation, like, oh, okay, whatever.
Hi, Dr. Montiel. Yes, my question is simple. So I've been listening to the whole presentation. I'm factor 7 deficiency. And I'm wondering, because I noticed you mentioned it in some of the others, are there certain ethnicities or certain parts of the world that this is more common to? Because I haven't had all this genetic detailed workup, but some members of the family have had some other things that show that we have some interesting heritage that apparently no one knew anything about. And so I'm just sort of wondering, right, is one of these pools, like, I don't know, we're Chinese someplace that no one knew about, for instance, does this come from someplace or does factor 7 show up all over the place?
Yeah, I mean, I think it's more of a cultural thing per se, because if you sort of look at certain areas of the world and certain sort of faith-based sort of analysis, that certain folks are just more likely to get together with people that they're distantly related, if not closely related to. So recessive disorders like factor 7 deficiency, when it's on the autosome, like not the sex chromosome, happen way more often in people that are in consanguineous relationships, or even, you know, more distantly than you would expect. Like the example I gave when I went to Turkey, the fellows there told me that 30% of the marriages in Ankara were between people that were first or second cousins, which is just a cultural norm. So, but they in that one clinic, I think I've talked to Dr. Baggio about this before. In that one clinic, I saw 20 families with Bernard-Soulier syndrome in one day, and 60 families with Lansman-Dietz. And I you know, go my whole career, 35 years so far, and have seen 4 or 5 people with Bernard-Soulier syndrome in that entire time. There I saw 20 families in one day. So it is more common, more culturally than it is ethnic. I think the gene frequency in various, say, if you want to say among the different races, is about the same. In the sort of the territories, if you exclude like closed communities, like the Amish community, for example, and then it's about the same.
I wanted to ask, and you started to answer a little bit about autosomal recessive, and you said it's not a sex chromosome, because I don't understand that fully, like it, so.
Okay, that took me years to figure out, so let's not even, we don't expect you to know it, right? So you've got all these chromosomes that do your blue eyes, 5 blue eyes, actually. And that's recessive
For an attack.
for an Italian, it's weird, right? My mother's Irish, my father's Italian. Northern Italy, I did the genetic thing. And my father, you know, the Italian side was Southern Europe. Big circle, Irish, Connaught Ireland. This county, Ireland, this area, they didn't go nowhere. They're Irish, they stayed there. So there are, so because like blue eyes is a really good example, that is basically autosome. The sex chromosomes really basically are your 2 X's make you female, 1 X makes you male. Basically. Yeah, that's what Y is for, right? So that's why I always like to say women are more powerful than the men because they have 2 X chromosomes and men only have 1. So.
Average.
But the blue eyes is a really good example because if you have one parent with brown eyes and one parent with blue eyes, the kids are all gonna have brown eyes. Because you have to have 2 blue genes to get the blue eyes. But you only need 1 brown. Brown is more powerful, it's dominant, so it takes over. Is that simple? That might be simple, but they take care of everything. Everything codes for everything. But the Y chromosome doesn't have a ton on it, so really it's only sort of saying male, female. And then hemophilia happens to be on that part of the X chromosome, the sex chromosome. So you get 26 chromosomes and You know, they code for everything, the color of my hair, my curliness, how tall I am, the cholesterol. You said sexiness. How much I talk?
I love that.
That's, I think, probably, oh, you said that, you said sassiness, I heard sexiness, so. But those are important things, so it's a really tough concept, just like the coagulation cascade. You know why we're specialists? Because the other doctors can't figure this stuff out. Or they don't want to. It makes sense. It makes sense to us a little bit, right? So this stuff makes sense. That's why we like it, because we kind of get it, but it took years to figure it out. It's not like I sat there the first day of medical school and went, oh, it makes perfect sense.
And it's really something special we have in the bleeding source site community, is we have this federal network of hemophilia treatment center of all these doctors who are very interested.
Yeah,
And
and
they all work together too,
yeah,
and talk to each other and share information, because, and
We-
it just is,
we have difficult cases and we go, what would you do?
yeah.
Did you tell me what you would do?
I read a couple of case studies, and it just is amazing. There's 6 or 8 doctors, and they go, well, here's where we start.
Well, we have a lot of people too, like, we've been talking about single bleeding disorders primarily, but I have patients with multiple bleeding disorders. So I have people with vulval gland disease and factor V deficiency, I have factor V deficiency and factor VIII deficiency, I have Lanzmann's and factor 13 deficiency. I have, you know, a factor 11, factor 10, and factor 7 family. I have a factor 11 liver family. You know, different people in the family have some of the different disorders. And it's, so just because you find one doesn't mean you should stop there, right? If the bleeding doesn't make sense, we continue with our workup to figure out, is there something else? Because remember that factor 13 doesn't show up on our screening tests. So we tend to check for that a lot. Or we look for the platelet function disorders a little bit more. In the future, maybe there are some different therapies coming out, these rebalancing therapies. Maybe something that's helpful for some people, where we inhibit the natural blood thinners. We have natural blood thinners. Antithrombin, oh, there he goes, antithrombin, okay, it's a rule, I didn't tell you all this, maybe he did. But, you know, when we become hematologists, we are mandated by law to show coagulation cascade for every talk. It's like a rule.
So you didn't get in trouble, I just drew.
Yeah. But we can, so then there's natural blood thinners, our body makes natural blood thinners, right? That we make protein C, protein S, and antithrombin, sort of help us so that you're not fighting all the time, it balances things out. And there are therapies that are reducing the levels of antithrombin, protein C or protein S, or this other one called PFPI, which is at the factor 7 area. That, yeah, too many words, but AT is antithrombin. And these are the drugs. Fitusiran is one which inhibits antithrombin. I've got several patients on that one for, they're studying it in hemophilia A and B. They're gonna study it in those first, because those are the patients that have severe bleeding, those are the ones that are, there's a lot of them. But could it be extended later? There's another one, concizumab, is the TFPI, tissue factor pathway inhibitor. One that also, they're all under the skin injections. Sorprenting has 5, there's all these different ones that are trying to reduce the natural blood thinners to stop bleeding. So those may be more generic, maybe more universal, I should say, universal for bleeding disorders. In the past, we've used Novo 7 a lot, factor 7, activated factor 7, sort of a little universally if we could, even though it's not approved for several uses. And some patients, if insurance will pay for it, which is usually our biggest barrier, but.
I was being your wing person for a second there, too. Because I knew I ran out of time, so I didn't show you these slides, but that was my sort of speculation for the future to sort of deal with the unmet need of not having a specific concentrate for your deficiency disorder, like factor 5 deficiency, for example. I don't know anytime soon we're going to get a factor 5 concentrate, But one of these medicines might be a way to get around that. And like the Fitusiran, like Dr. Baggio said, that works on reducing the amount of antithrombin we make. And that sort of allows your deficiency of factor to be rebalanced by making a deficiency of a natural blood thinner, right? And there's evidence that that could work, right? Because antithrombin especially is a perfect target because I think I have this.
He had the thing, he was so clear in the back, I didn't even realize.
Antithrombin is like your body's most important blood thinner, right? Because you can't be born, nobody's been born without it, so it's essential, right? And we do know that some people are born with not enough of it, and we know they clog their blood too much. I have a whole clinic of people that are deficient in antithrombin, about 30 or 40 of them that have terrible blood clotting. We getting ready to close?
Oh, no, I'm stretching.
Okay.
I'm a stretcher, I'm sorry.
Yeah. Okay, so if you reduce antithrombin, you potentially. And that, while you're walking over, that was just done in an experiment in mice with hemophilia. We reduced their antithrombin, they stopped it.
I have factor 11 and I've developed antibodies, so I had to take Novo-7 for tooth extraction. Thank goodness, thank God for her. Fighting the insurance company again. I just want to, I'm going to need a new replacement pretty soon. And will I continue having these antibodies or will they go away and they come back or?
Yeah, the antibodies come stay, they stay, the antibodies stay. So we have to use a bypassing agent. It's up, it's in the. It's in people with hemophilia A and B, we give them immune tolerance therapy, we just give them a ton of factor until it goes away, until the inhibitors hopefully go away. It's not always successful, but we deal with platelet disorders. If they form antibodies, the platelets aren't really all that effective. If you have a factor 11 deficiency, the antibody against factor 11 is not effective, so we have to use the bypassing agent, which would be the recombinant factor 7A. No, it keeps going up in price, but this 7 fact is a different choice, so, but the price, when I started, almost 7 was $1.39 in my range. $2.10 now, my range, so. Keeps going up, but it's, you know what, but there's no price to control bleeding. And for life, right, so we can't put a price on that, that's somebody else puts the price on that. We don't put the price on that. We put the price on people being well, being healthy, being in control of their bleeding, that kind of stuff. That's our focus is that it's more important that people get the treatment they need. We do the argument with the insurance guy. And I could say, now if you ask me on Friday for your procedure on Monday, to get it back for you, it's not gonna happen. It can take 2 weeks to a month to get all the prior auths and appeals and all that kind of stuff, so
Well,
that could happen.
you start with a super rare bleeding disorder, and then you add sort of a pretty unusual complication, a neutralizing antibody. So that makes it even less like out there in the sort of the knowledge bank on what to do with that. I mentioned that, those couple of patients we had with acquired factor 13 deficiency, meaning they were making antibodies against their own factor 13, immunity against their own factor 13. So there is some literature on trying to get rid of those antibodies. I know there's not really any literature on trying to do it for factor 11. And I'm sure Dr. Baggio has already thought about it, but there is some literature on getting rid of like factor 5 antibodies with immunoglobulin, factor 13 antibodies with this drug called rituximab.
Right, just like we do the factor 8 inhibitor,
Right.
which is also extremely rare to have an acquired factor 8 deficiency. Or acquired liver deficiency, which I have too. But you use immune suppression. You do immune modulatory therapy to try to get rid of the antibodies that's there. But if it's an auto, that's a little different than being exposed to factor 11 and then having antibodies against the factor 11. Perhaps we have to figure that out.
Okay, I think we could be here all day, so I want to thank Dr. Gentile and Dr. Baggio. If everybody doesn't mind, can we get a picture while we have almost everybody? So come up here to the front and we'll have I'd really like to show Global Genes. You know, Philly Alliance is here. Picture of everybody that was with me.
You want the Tennessee perfect?
There you go. That's a perfect.
Bob, do you want me to pause this recording?
You can stop that now. Thank you. But if everybody just come up quickly,